Welcome to Ultrasound Guided Arterial and Venous Access. There are two objectives with this video. We wish to demonstrate how ultrasound can facilitate radial artery catheterization and demonstrate how ultrasound can facilitate peripheral intravenous catheter placement. Disclaimer: there are multiple approaches to using ultrasound to image structures and insert needles. This video will demonstrate the author's preferred approaches for both arterial and venous access. Terminology: we will be imaging the radial artery and peripheral veins in short axis. We will insert the needle using the out-of-plane approach. For technical summary of these two concepts, please see the video Introduction to Ultrasound Guided Regional Anesthesia available on this website. Peripheral intravenous access. Patient's arm should be placed on support rest. While imaging the vein in short axis, center the vein in the middle of the screen and note the depth. Then mark the skin site with a pen directly over the vein. Move the transducer 2 to 3 centimeters proximal and make a second mark on the skin. You now know the trajectory of the vein. At this point, you know the location, depth, and trajectory of the vein. You can simply place the ultrasound machine down and cannulate the vein in the traditional non-ultrasound manner that you are familiar with. This video demonstrates this process. The first skin mark is made here, the ultrasound transducer is moved proximal, and a second skin mark is made. Since you know the trajectory, you would simply now insert the needle as you normally would. Alternative approach: perform standard aseptic skin preparation. Using a live technique, perform an out-of-plane needle insertion technique. When the blood is visualized in the needle, place the transducer down and finish the procedure in a traditional fashion. This video demonstrates this technique: out-of-plane needle insertion. The ultrasound inset video will demonstrate the short axis view of the vein. The needle is now crossing the tip of the ultrasound beam. When blood is seen inside the needle system, the ultrasound transducer is placed down and the procedure is finished in a traditional fashion. Artery versus vein. This is a good time to make the distinction with respect to ultrasound imaging. Arteries are pulsatile, veins are not. Veins easily collapse with transducer pressure. Be careful with using color Doppler to distinguish between arteries and veins. As described in the introductory ultrasound physics video, short axis imaging may not reveal flow in an artery. Here's an example of the pulsatile radial artery. Look carefully. Radial artery access. Technique 1. Conduct similar ergonomic setup as for intravenous access. Perform aseptic skin preparation. Image radial artery in short axis. Then perform an out-of-plane needle insertion technique. When blood is visualized in the arterial catheter device, advance the needle through the posterior wall of the artery. You know that you have gone through the back wall, i.e. posterior aspect of the artery, when blood stops flowing. This is commonly referred to as transfixing. Finishing the procedure. After transfixation of the artery, place the transducer down and finish the procedure in a normal fashion. Remove the needle and withdraw the catheter. Following identification of pulsatile flow, insert a guide wire into the artery. Advance the catheter over the wire and remove the wire. These techniques are demonstrated here. The following ultrasound image demonstrates short-axis imaging for the prior patient. The image also demonstrates a useful artifact. The radial artery is indicated in red. This artifact is called a comet tail and is caused by ultrasound reverberation within the needle. Recognizing this artifact, the operator confirms that the needle is correctly positioned above the artery. Had the comet tail lines not passed through the artery, I would infer that the needle tip is either lateral or medial to the artery. The comet tail lines are indicated by the green arrows. You can see that these hypoechoic lines are passing right through the artery, suggesting correct needle tip location. Technique 2. This is similar to the venous access approach in which the artery is marked in two locations. You then proceed in a traditional manner without ultrasound. This is being demonstrated here. Here is the first skin mark. Then the transducer is slid in a proximal direction. And a second skin mark is placed right over the ultrasound identified location of the artery. Clinical pearls. In the live techniques, do not get so distracted by the ultrasound image that you miss the fact that you have blood in your needle. When the ultrasound image confirms that the needle is lined up nicely, but still superficial to the vessel, I will usually switch my vision to the needle looking for blood as I advance. Summary. Both venous and arterial access can be facilitated by ultrasound. For both, there is a live technique and a marking technique. Artifacts can provide helpful information.